Hi to everyone and welcome to the episode of today of Pop Talks Mini Cases. Today we have a special guest from Riyadh. I suppose that Zaher is in Riyadh now and not in Syria. Welcome, Zaher.
Welcome,
How are
Fabio.
you?
Fine, how are you?
Fine, thanks. And you?
Fine, doing well,
Are you
staying home
stay home?
as usual.
Are you in Riyadh or
Yes, I am now in
in,
Riyadh.
in Riyadh?
In Riyadh, yes.
Ah,
We
yeah.
have a court
I
house
know, I
and we
know, I know your home. I know your home.
yes, the master.
I know. Okay, so today we'll discuss about calcified canals.
Yes,
Okay, about some tips and tricks, and so usually calcified canals are very tricky cases.
exactly. Calcified canals, calcified bulb chambers are difficult situations for the clinicians to perform the root canal treatment. Many mistakes could happen, perforations, a lot of tissue structure could be removed.
So from simple cases to very difficult cases.
Yes,
Okay,
we have
okay.
clinical situations according to the classifications we have. So we will check together now the presentation, and hopefully we will give some tips and tricks for all the audience and the colleagues who are live now with us. Thanks for you for sure for the
Okay,
labor for the labor.
I will I will collect some questions for you. So during your presentation, I'll stop you and we can discuss about a little bit about the questions. Okay.
Yes. Okay. No
Okay. Are
problem.
you ready? Are you ready?
Yes. Ready.
Okay. So you can
So
go.
let's go. Let's go for the presentation. Okay. Remove these obstacles. And clinically, the situation with the calcification may be different. Not all the calcifications are the same. Sometimes we have only bulb stones, as you can see, and this is the simplest calcification cases. Maybe we can remove the bulb stone with ultrasonic test with kind of magnification. Loops are more than enough here, and sometimes we have a big bulb stone, so it's a little bit tricky. We can divide the bulb stone into two pieces, remove the first one, and then trying to remove the other one also with ultrasonic, as you can see here, or with some sharp endoprobe. And whenever we remove the bulb stone, we gain again to the bulb space, and then we can negotiate our root canal, and we can also complete the cleaning and shaping process. The second type of the calcification of the clinical situation we may face during the root canal treatment is the sclerotic dentine, as you can see in this case. The sclerotic dentine is a little bit tricky because we don't have any bulb stone inside the bulb chamber, and we have to remove all the sclerotic dentine to reach to the bulb floor. Like in this case, you can see here the image. I don't have any bulb stone here. We have only sclerotic dentine covering all the bulb chamber. So we will talk about later how to manage such cases. And the third clinical situation we may face, which is the hardest one, when we have a calcification going inside the root canal. So calcification starts from bulb stone, the easiest one, then sclerotic dentine in the bulb chamber only. Then when we have calcification or calcified canals inside the root canal, we may call it dystrophic calcification or root canal obliteration. As you can see here, the mesial canals are completely obliterated. So what are the causes for such calcification? Many causes or many factors affect the calcification process, such as age of the patient, the repeatable big and old restorations, the secondary caries, trauma or cracks, and sometimes the vital bulb therapy. So many factors may affect the process of calcification. We need some tools to manage such situations, and the most important one, in my opinion, is the magnification and the microscope. Because with microscope, we can see better, we can differentiate between the calcified tissues and the bulb floor, as we will see later. Also, we can use an important tool to use is the 3D cone beam. They guide us to the root canal orifices. They give us many important information about calcification. Also, ultrasonic tips, diamond, stainless steel, non-coated and coated tips, micro openers, stiff manual files like C files, for example, canal detectors like methylene blue, and also EDTA gel for the glide path management of the manual. So what is the management for such case or for such cases? If we are talking about management, we have to know something before. The floor map colors. In endodontics, we have colors. And for that reason, we have to differentiate between the colors of the floor map and the colors of the axial wall. This is the most important tip when we are dealing with calcified bulb chamber or calcified cases or calcified teeth. So the floor map contains color. The floor map usually darker in colors than the axial wall. The dentine there is darker. And inside this map, we have, or inside this floor, we have a map. This map is usually a dark lines connecting the orifices. So we have a guide. We have a guide, and hopefully we have this guide to guide us into the root canal orifices. So we have to follow this guide. Dark lines connecting our root canal orifices, and then we can proceed to the root canal system.
Zaher, we have a question that's probably is interesting to discuss in this moment about pulp stones. Does pulp stones in pulp chamber affect the success rates of endo treatment? And if I leave the pulp stone there and I go straight to the access, leave it, so probably it will change something in the outcomes or not?
Yes, very nice question. Actually, we have to remove the bulb stone completely, because under the bulb stone we have bulb tissue, and we cannot leave any bulb tissue inside the bulb chamber. So we have to remove the bulb stone completely. As I said, with any kind of magnification, we can do the job. Leaving the bulb stone and doing the shaping with the rotary file is a little bit risky, because we are increasing the surface of maybe contacting the bulb stone with the file, and so more stress on the file. So why to do that? Simply we can remove the bulb stone and complete our root canal treatment.
And in your opinion, is possible to manage the pulp stones without a microscope or not?
Yes, without microscope, it's possible for small or a little bit bigger bulb stones, while for completely calcified bulb chambers, no, we need a microscope.
I agree. Go ahead.
So, okay, so now to the second case or clinical situation for the calcification, we can see in this upper molar, we have a sclerotic dentine. We have no bulb stone here. In such cases, according to the last question, in such cases, we have to use magnification. We have to use microscope, sorry. We have to use microscope because loops cannot do anything here. You can see the bulb chamber is completely calcified, and I am trying now just to know where is the outline of my bulb chamber, and with the sharp endoprobe you can just examine this area. Then you have to use the ultrasonic tips, diamond tips for sure, to remove the sclerotic dentin. And always follow the outline of your axis, of your pulpit chamber, or of your floor map. You have to follow the dark line, and you have to remove all the bright dentin until you reach to a darkest dentin, or the dark dentin, which represents the floor map. Always irrigate, and after irrigation, the tip here is to dry as much as you can, dry the bulb chamber, because with more dry, you can see better and you can differentiate the color. You will see now with more magnification, I am seeing better the color, and still I have some bright dentin here on the mesial side and in the middle of the bulb chamber, and here on the palatal side, I have to remove more sclerotic dentin. Then I will reach to my floor map, or my dark or darkest dentin, which represents the floor map. You can see in this slide, the first image on the left is the situation before starting. Then after some roughing with ultrasonic tips, still I have bright dentin, and at the end we have dark dentin, and we are now reaching our bulb floor, mesiobuccal 1, mesiobuccal 2, distobuccal, palatal. Now I don't have any problem. I can negotiate the root canals. They are narrow but not calcified, because here the calcification doesn't go inside the root canal. So the tricky tip of this of such cases is to remove the calcification properly without any mistake, without removing too much dentin, without sacrificing the crown. So here is the X-ray before, and here the X-ray after normal root canal treatment after removing the sclerotic dentin.
Do you have any tips to increase the difference in terms of color between calcified tissue and dentin?
Yes, we can use sometimes the canal detector, which is the maybe red foxine, maybe methylene blue, just to differentiate between the color. But usually, when you dry the bulb chamber, you will differentiate between, and with a very high magnification, 16 or 20x, you will differentiate between the bright and the dark dentin. Any other question?
Yes, about if you are using ultrasonic tips without water or not
Yes,
during the locating of calcified orifices.
yes, sure. I use the ultrasonic tips, or we have to use it without water. Maybe you can put some drops of EDTA or sodium hypochlorite just to prevent the debris from blocking your view. But sure, you have to use it without water to enable you to see more the colors and see where are you cutting.
And have you never used alcohol just to dry
Yes,
the pulpal floor?
it's very useful to use alcohol, but actually I don't need it because I can dry it with air enough, and it's more than enough to dry it with air completely, and you will see the difference in the color.
Okay, go straight.
Okay, now the question is when to treat calcified teeth. You can see on this X-ray upper two central. You can see the difference in the size of the pulp chamber, and on the left central we have calcified pulp chamber and a little bit narrow canal. So this X-ray belongs to me. This is my tooth. I had a trauma maybe 15 or 20 years ago. I fall on my bicycle, and I had trauma on my central. So till now, I don't have any signs or symptoms regarding the central. the left central. I have small composite here between the two centrals just to close the diastema. I need to replace it, but I have no any symptoms. So why to do root canal treatment for calcified teeth without symptoms? Usually, we do root canal treatment for calcified teeth when we have symptoms and we have radiographic findings. So when we do X-ray, we found the periapical lesion. It's okay. We have to go and we have to open the root canal. We have to remove the calcification and we have to clean and shape our root canal system because we have necrosis and we have necrotic pulse. But when we don't have any symptoms, like my tooth, this is my central for more than 20 years. I will show you now. Just a little bit yellowish in color. So, in my opinion, many colleagues are trying to do root canal treatment just because they are seeing calcification. And this is an important tip that we should not do root canal treatment for any calcified tooth because maybe the bulb inside will still bite. And for me, I don't do any root canal treatment for calcified teeth unless I have symptoms or radiographic findings.
An interesting question about at what point during the treatment do you decide to stop the searching and go to the CBCT scan?
Yes, very nice question. Actually, I always try to avoid to use CBCT scan. And when in calcified teeth, I try always to open the tooth directly without CBCT. Then, when I couldn't or I cannot find any the root canal orifice or I feel that I am lost, I can inject some radio-opaque materials such as maybe bioceramic sealer or calcium hydroxide. Just inject inside the bulb chamber and do the CBCT. Then it will guide me through where I was drilling, or it will guide me again through the orifices of the bulb chamber or of the root canals. So I stop when I feel that I am lost, and I spend two maybe visits without any proceeding or without any improvement. I stop and take a CBC.
Another questions this I think this is a really interesting about the micro guided endodontic uh, treatment. When do you suggest to use it? If for you is useful or not? Any
Hmm.
suggestion?
Yes, it's maybe it's useful, yes, for severely calcified teeth, but for me it's a little bit time consuming. It's a little bit uh, difficult procedure for to do the guide and start drilling. Maybe if we follow the problem with calcified teeth is only located in the coronal or a little bit in the coronal middle part of the canal. And with very high magnification, with precise ultrasonic tips, we can remove such calcification and start negotiating the canal. Because uh, maybe at the end of the treatment, you will feel that you catch the canal and you did the root canal treatment without any problem. The problem is just in the bulb chamber and in the middle and coronal part of the canal. And this is very easy to do with high magnification and with the tools for sure. And the most important thing is to differentiate between colors.
So is I agree with you, but probably this is my suggestion. We have to discuss more about the micro guide for in endo in normal treatment or in surgery, and probably we can do a pop talks with more speakers just to discuss about these important topics because
Yes,
in my opinion we have cost and benefit, so the selection of the cases is very very important.
for
And
sure.
mm, often we see in the web that some colleagues are pushing a lot the guided endo uh, without any discussion about the balance between cost and benefit. So it depends on the experience of the clinicians, depends if you are using microscope or not. It depends on many aspects. But this
Yes,
is an interesting topic. So, in my opinion, we were to organize a special pop talks only on this topic.
for this topic. Yes, I agree.
Mm. Go ahead, Francesca. Thanks.
Okay, let's go back to the slides. So let's check together this case. So we say that in a calcified teeth, we don't do the root canal treatment if we don't have signs or symptoms. Uh, this patient came to me with a slight pain on the lower left region. He said that I have a slight pain in this area, and I don't know which tooth exactly. So I did my examination. I take the periapical X-ray. I couldn't find any periapical pathology. I did the percussion test. Nothing is clear between the 6 and 7. Vitality test for sure is not a valuable test for calcified teeth because the bulb chamber is calcified. So the test is useless. So I told the patient I couldn't see any problem, but when I checked her file in our system in our center, I saw that she has a CBCT done 6 months before to do an implant on the upper right area. So also I checked the cone beam for this patient, and I found everything is perfect, no any periapical lesion, and everything is going well. So I told her just relax and try to use your night guard because she is a proximate patient. Just use your night guard, and that's it. Nothing is maybe she was very afraid. I said it's okay. Just go home and let me see you after maybe 1 week, 10 days, and let me what will happen. So she came back to me after 1 week with severe pain, very severe pain, complaining from the tooth number 7, and she said this tooth is hurts a lot. So in this part of the maybe the examination, here I did another CBCT before starting to see what is happening. And look at this. With the new CBCT, after 6 months from the old one, you can see the periapical lesion on the distal root. So now we have no choice. We have no choice. Now we have to do the root canal treatment. Despite that, on the periapical X-ray, we can't see any lesion. But with the CBCT, the new one, we can see clearly the periapical lesion, and now we have to do the root canal. Despite that, the tooth is intact, no any caries, and nothing. But I think because the patient undergoes accident and she has surgical splint, that's why maybe there is a trauma, and that's why the bulb in this tooth or in this lower molar was necrotic, and then start to uh, do the problem for the patient and the infection. So we started as usual with our initial outline with the pair. In this stage of access, you have to take multiple X-rays, periapical X-rays, to check clearly that you are centered and you are not going beyond the floor. You are not going very deep. Because if you go deep about 1 millimeter and you start going nasally, distally, buccally, lingually, as usual, you will lose or you will lose the floor map, which is the most important thing to go back to the root canal orifices because we need the floor map to guide us to the root canal orifice. As you can see here, I have calcified tissues. The bright dentine is the calcification. I have to remove all the calcification with ultrasonic tips. So with diamond tips, I will start to remove the calcification. Then I will shift to the stainless steel tips, non-coated, ultrasonic tips, just to break up the calcification more. And now you can see in this X-ray or on this image that now I can see more colors. I can see dark dentine. I can see some points on the mesial side and also on the distal side. But the problem here that the calcification goes inside the root canal also. So here we have obliteration and dystrophic calcification inside the root canal. So I have also to trap the calcification and try to break up the calcification inside the root canal with the ultrasonic tips, thin and non-coated ultrasonic tips. Another tip is to take X-ray while you are drilling inside or you are trapping the ultrasonic inside the root canal is to put the ultrasonic tip inside the distal root and take an X-ray. This will tell you that you are drilling in the right way or not. So maybe also you can, if you are tired, you can close with the TF and inject their calcium hydroxide and also do an X-ray to see if you are going with the long axis of the root or not. So according to this X-ray, with the ultrasonic tip, I need to go a little bit on the inner wall to catch the canal because the canal is calcified only in the coronal third, and in the middle third, I can catch the canal there, as you can see on the lower left X-ray. So in the next visit, with the manual K files, fifth K files, pre-care, and go to the inner wall. And you can see we catch the canal easily and we reach the working length because the calcification was only on the coronal and middle and a little bit of middle there. After that, you can proceed with your normal root canal procedure and do the same for the mesial root canals also. Remove calcification with ultrasonic tips, glide path with the manual K files. When the 10 K file is loose at the working length, try to use the rotary glide path file to enlarge your glide path done with the manual files, and then to the shaping. During the shaping process, be careful because it's a very narrow canal. You have to shape it carefully. You are using multiple files or using single file. You have to brush the walls, go out, clean or irrigate, recapitulate again, and then go again to the working list. So after shaping, as I told you, it's a normal root canal treatment. The obstacles are only on the coronal part. We have to clean the root canal activation. And now you can see here the floor map colors. Look at the difference. We have a different colors. On the axial wall, we have bright dentine. On the floor map, we have the dark dentine. So the floor map is there. Just we have to search about it. The colors are there. Just we have to magnify as much as we can and dry as much as we can and remove the bright dentine and the calcification. Then 3D obturation as normal, continuous wave or warm vertical condensation or compaction. Here is the pre-op and the post-op X-ray. You can see clearly that the axis was strict to the root canal. I have straight line axis and it was strict and a little bit maybe contracted because I don't want to open big axis because in calcified teeth you have to be strict to the floor map. You don't need to lost yourself and try to search in a bigger area. Stay small, but stay straight line to the root canal or to the root canal orifice. Another case also upper molar, completely calcified bulb chamber, but the patient has symptoms. She has pain on percussion. She cannot fight on this tooth. And she came to me, she said, I cannot fight on this tooth. I have severe pain. When I do the percussion test, yes, it was very severe. And I think if we took a CBCT for this case, we will find the periapical lesion on the distal root because I can see some periodontal ligament widening there. So in such cases, we have to do the root canal treatment. As usual, initial outline, and you can see here clearly the calcification or the calcified tissues. The reparative dentine, the tertiary dentine are totally deposited in the bulb chamber, blocking all the floor and blocking also the orifices. So with magnification, in this area, exactly in this area, you can see the bright dentures. So with magnification, with ultrasonic tips, you have to break up these calcified tissues slowly, dry, re-evaluate, and then go again with the ultrasonic tips. You can see now I am reaching to the dark dentine. I am reaching to my floor map, and you can see I have already removed the calcification over the mesiobuccal canal. But still, I have some white spots on the distobuccal orifice and also on the palatal side. So I have to remove again the calcification on the distobuccal and palatal, and then everything will be okay because the root canals are not calcified. The only calcified part of this tooth is the bulb chamber. So when we remove all the obstacles in the bulb chamber, we can proceed to the apex with the manual file 6, 8, 10, and then enlarge the glide path, and then complete our root canal treatment. You can see on this also image. Now I can see clearly the three orifices, mesiobuccal 1, distobuccal, and palatal. But unfortunately, I couldn't find the MB2. But because my luck is super, during the obturation, you can see the X-ray. I have the MB2 obturated only with sealer because of warm obturation, and that's good. That's fine.
Zaher,
Yes.
I try to resume some questions for you.
Yes, please.
Mainly, we have two topics. The first one is when we don't have any lesion on a calcified canals in multi-rooted teeth, it's
Yes.
possible to leave it, don't treat it. What do you think?
Yes. It's possible to
Maybe
leave it.
maybe we have a lesion in mesiobuccal and not in the distal. So what do you
No.
manage
If
the
the
situation?
calcified tooth, yes, if the calcified tooth was totally asymptomatic and there is no any periapical findings, no any periapical pathology, we have to leave it because maybe the bulb inside is vital. But
Yeah, but the
when we
question is about, sorry, the question is about a multi-rooted teeth where in one root we have a lesion and in another root maybe not. And one is not, and the canal is completely calcified. How do you manage the situation? You can leave that canals completely untreated, or in any case, you try to reach the apex.
now I understand the question. Actually, I don't recommend to leave to treat two or three canals and leave one, because if we have a lesion on one root, so we have a necrotic pulp. So for sure we have necrosis in the second or the third root. That's why I don't recommend this. Maybe later we will have a lesion on this root. So if we have to start the root canal treatment, we have to treat all the roots as much as we can. But I said we need tools, we need patience, we need more than one visit, and we need at least 2 to 3 visits to open the root canal in completely calcified teeth. So it needs patience.
And you have more questions about frontal teeth with discolorations, completely calcified canal, but with no lesions. Is an aesthetic problem. How do you manage the aesthetic problem, and if it's necessary or not to do the endodontic treatment?
Yes, like my tooth. My tooth is calcified and I have a little bit discoloration. So I have no symptoms. If there is no symptom, I will. It's like that for more than 15 or 20 years, and maybe the patient also will tell you that it's like that for more than 15 or 20 years. So if we don't have any symptoms, we have aesthetic problem. We can cover the problem with veneers, with direct composite or indirect restoration. If you can do the root canal treatment, it's okay. If it is completely calcified, you don't have the tools, you don't have the experience with the calcified teeth, please don't try to do it because many times when we are trying to do the root canal treatment for calcified teeth, we we produce or we have another problem like perforation in the buccal area of the anterior teeth or perforation in the palatal area. So, or maybe we destroy the root because we are drilling with our bears inside the bulb chamber. So it was uh, very, very maybe destroying for the tooth. And it was asymptomatic for more than 10, 15, I don't know. But it was asymptomatic for years. And then to do the aesthetic part, we destroyed the teeth, or we destroyed the tooth. So try to be conservative as much as we can. And if we have symptoms, for sure, we have to do it.
In your
And don't forget,
opinion, is the surgery could be a nice solution in cases like this, or not?
I was
Directly go to the surgery.
I was just about to say that. Don't forget that we have another choice, which is the last choice, the periapical surgery. When we couldn't negotiate the root canal and we have aesthetic problem and we have to solve this problem for the patient, we do maybe the crown and then we have a lesion and we have symptoms on this tooth, we can go for surgery. It will be more easy because the calcification, as I told you, usually not reaching to the last 3 or 2 millimeters for the canal. When you negotiate the canal from the middle third, you can negotiate it to the apical third. So in the last 2 or 3 millimeters, it's not calcified. So in the apical surgery, you can see the root canal exit or the portal of exit clearly with methylene blue. For sure, Fabio, you can discuss this part more than me. You can see it clearly, and you can do the tetroprep and tetropin.
Other question is about if you prefer uh, ADTA in gel or a normal ADTA just to facilitate the shaping in calcified canals.
Yes, for EDTA, I use always EDTA gel with the manual file. With the step C file, I use EDTA gel just with the manual file. Then when I have my 10K file loose at the working length, starting from 6, 8, then 10K file. When I have 10K file loose, I don't use EDTA gel. Then I shift to the sodium hypochlorite only with the rotary file.
We have a lot of questions. It's very difficult to manage it, but some questions are about the shaping. If you are using rotaries, which protocol do you use in calcified canals? Only rotaries, manual, and then rotaries?
Yes, very nice question. Usually for calcified canals, we have to change a little bit our approach, but uh, in general, it is the same concept. Step down technique. Step down technique. First of all, when you catch your orifice with the manual file, remove the manual file and go a little bit with the glide back pre-flaring file, which is taper 2 or taper 3, 15 or 10. Just 2 to 3 millimeters inside the root canal orifice, just to flare a little bit and then irrigate well. Then go with your manual K file again and try to do the glide path till you reach to the working length. Then flare again for more 10, 15 millimeters, and then define your working length and start your shading process. So in general, step down technique, but you can use more the pre-flaring file for 2 millimeters, 3 millimeters, then manual file. Then again, 2, 3 millimeters, then manual file. Until you reach to the apex with your manual file, start to glide back and lose 10K file is done, then go with your manual or use your usual protocol to, according to your file system.
Another question is about uh, the workflow of the calcification. Why the calcification appear in the coronal part or in the middle part of the canals and not in the apical one third, and why?
Very nice question. Because the response of the bulb, when the bulb wants to defend himself, The response of the bulb is to provide or to put the deposition or to deposit the tertiary dentin or the reparative dentin. The reparative dentin starts from the pulp horns and then go to the apical area. So we will start from the bulb horns, then to the bulb floor, and then to the root canal. That's why we usually we don't have calcification in the apical area, because the process starts from the bulb in the bulb chamber. The process of deposition of the reparative dentin.
One of the last questions is about the manual motion. Watch winding or up and down?
No. For calcified canals, we can use watch winding a little bit and balance force. It's better than watch winding. Watch winding a little bit, then when you have stuck, you can do the balance force and go up. Up and down, not working for calcified canals. You have to open the road. So watch winding, remove, irrigate, then do one balance force, then remove, irrigate, then watch winding again until you reach to the working road.
We have other questions about the surgery directly to the EPS, but we already replied to these questions. And I don't know, do you have any other slides?
Yes, I have
Okay,
maybe
so
the last.
go forward, because we are in delay.
Okay, so let's see this case together. It's about central incisor also, and I am showing this case because in this case I have no any symptoms. I have no any symptoms with the patient, no any radiographic findings. I have a calcified bulb chamber. The canal starts at the coronal part or near the cemento enamel junction. So why we have to do the root canal treatment here? You can see clearly on the X-ray because I have internal resorption. So when we have an internal resorption, we have to stop the process of the resorption. So we have to do the root canal treatment here. Despite that, the patient has no any symptoms and he is asymptomatic for many years. But because we have a resorption and according to the CBCT, you can see clearly the canal starts here on the cemento enamel junction, and then the internal resorption inside. Hopefully, it was not connecting with the periodontal, no connection with the resorption and the periodontal ligament or the bone. That's why we can do the normal root canal treatment and the filling maybe the Faberca and sealer because there is no any connection with the periodontal. When we have connection, we can do the operation with another biocompatible material, NCA, biotin, or bioceramics. As usual, start with your initial outline. In anterior teeth is a different story. Why I am showing this case? Because in anterior teeth, the calcified tissues forms a ring calcification. It's called ring calcification. We have a dark spot. We don't have a floor map here. So we will not see the floor map because this is a single rooted tooth. So we will see only a dark spot. And we have to follow the dark spot with our magnification and our ultrasonic tips. You can see here dark area. So go with your ultrasonic tips. Try to be as much as you can with the long axis of the root, drilling with or troughing with the diamond tips, and as usual, irrigate, then dry again, dry as much as you can, and you will see the ring calcification, as you can see here. With more magnification, here we are about 20x, you can see here the ring calcification, the dark spot. Now it's clear, yes. So this is the root canal orifice. So with some watch winding motion with the micro opener, you can negotiate this orifice. Then you can go with your free-flaring files, and then it will be very easy to reach to the apical area because the obstacle was only in the coronal part. Here is the post-op X-ray, and as I told you, I did the filling with the Faberca and sealer. for the internal resorption because there is no any communication with the surrounding horizon. So I think this is the final case. Let me check. Yes, the final case or for today, I have slow connection a little bit. Yes, this one. So if you see this axis and you can see clearly the data Berka for MB1, MB2, histobuccal and palatal, you will see that everything looks great. But according to the X-ray, you can see that we have a missed mesial root because of calcification. Because of calcified mesial root, the previous dentist couldn't negotiate the root canal. He drilled in another pathway, so he stopped. And this is a very good thing: is to stop when you couldn't find the root canal. Don't drill more, otherwise you will perforate the tooth. So he stopped, and then he do the final restoration and the operation. And he told the patient, we will reassign the tooth or we reassess the tooth after maybe 3 6 months. And after 3 months, the patient started to have pain on biting, and the tooth was sensitive to percussion. So he referred the case to me, and according to the X-ray, I have to open the root canal because I have symptoms now. So with more magnification, and when you dry the bulb chamber after the ultrasonic tip scrubbing on the medial side, dry as much as you can, and you will see the root canal orifices clearly. Here is the MB1 and here is the MB2. Why? Because I have a dark lines connecting the orifices. As we said, the floor mat, the most important thing. Try to follow the dark lines, and you will catch the orifice. Here, it's very difficult to put your manual K file directly in the orifice. So I go directly with pre-flaring rotary glide path files just to open 1 to 2 or 3 millimeters of the root canal, then start negotiation with the manual files. It's very difficult to put your manual files directly inside this very narrow and calcified canal. After that, normal cleaning, shaping, and operation. So I think I have done.
Okay.
So
We
thank
have
you
a
very much.
couple of questions, more questions here.
Yes.
One is about the difference between diamond or stainless steel ultrasonic tips. What do you prefer to detecting calcified orifice?
Very good question. For diamond tips, for calcified bulb chamber, I use always diamond tips to go back to the floor mat because it's more efficient, it cuts more, and it's faster. While for stainless steel, ultrasonic tips, I use it when I have a calcification inside the root canal because the diamond tip is very big, so it will not go inside. I use the thin ultrasonic stainless steel tip just to remove the calcification inside and gain the access to the root canal. So the more efficient tip is the diamond, but we cannot use it inside the root canal, only in the bulb chamber.
Another question is about the ADTA. How long in contact with the canals and with the calcified canals to remove calcifications?
How long?
The colleagues probably he wants to understand if it's possible to leave ADTA inside of the canals just to
How long can we? Okay. Yes.
solve the problems.
Yes. Yes. A very famous question. We always have this
Very
question.
famous question.
Yes. Can we leave EDTA inside so the canal will open? No. The EDTA will not. That EDTA will not do anything without your mechanical negotiation, without your files. So EDTA helps you just to remove the smear layer and help you for the as a conditioner for the gliding, especially the EDTA gel. But without the mechanical action of your manual files and your finger, nothing will open. So we don't need to leave it inside the root canal.
Okay, let me check if we have other questions. we got a lot of questions. Some questions about your internal resorption cases.
Yes.
How do you manage the resorption? If it's better to use bioceramic or one at a percha to fill it, or how do you clean that area, and so on?
Very nice question. Usually for internal resorption, we have to clean and we have to agitate our irrigant solution as much as we can because we have irregular shape. And by the way, my thesis for my master degree was about internal resorption. So during the cleaning process, you have to clean as much as you can, and you have to put some calcium hydroxide for 7 or 14 days because we have to stop the process and we have to eliminate all the granulation tissue there. After that, you can fill the resorption with warm gataperca. If there is no communication with the periodontum, as I said, if there is a communication with the periodontum, we have to use another kind of material, which is bioceramics or MTA or biodentine, for example.
Okay. We spent more than 45 minutes, so probably is enough. Thanks,
Yes.
Zaher. Thanks, Zaher, for the gorgeous presentations.
Thanks for your effort.
Take care, and
everyone.
take care of all of you. And thanks,
friend.
Diego. Thanks, Francesca. And see you for the next episode of Mini Cases Pop Talks.
Thank you very
And
much.
stay tuned with Still Italiano Endodontists. Bye-bye.
Bye-bye.